Hi there, I would like to discuss a case with you to get your input. So, 3 years ago, Alice was diagnosed with a stage 3 ER-positive HER2-negative breast cancer at 53 years of age. The patient was premenopausal at the time of diagnosis. She received adjuvant chemotherapy and became amenorrheic. So she was started on tamoxifen with the aim of switching to AI plus or minus ovarian function suppression after 2 years. Unfortunately, 16 months after treatment initiation, she underwent abdominal ultrasound to monitor benign liver lesions, which revealed 3 liver mets that were confirmed at the CT scan. A biopsy was performed, followed by immunohistochemistry, and the results showed 93% ER positivity and HER2 score 0. Genetic testing was conducted at the time of diagnosis for familial history, not revealing germline BRCA1 or 2 pathogenic variants. So we have now Alice, which is diagnosed with ER-positive HER2-negative metastatic breast cancer, and we decided to offer first-line treatment for metastatic disease with abemaciclib in combination with anastrozole. Alice is now back in clinic for her routine follow-up visit. We are 20 months after treatment initiation, and the CT scan showed disease progression of liver metastasis. The progression of liver metastasis suggests now the need to reassess the treatment plan and to consider alternative or additional treatment options. Now the patient has progressed. I would like to check for possible actionable targets to choose the best treatment strategy. Which mutations would you test for? If you choose a SERDS mutation, it's important to discuss that these mutations are highly prevalent in ER-positive HER2-negative metastatic breast cancer, particularly after developing resistance to AIs. These mutations occur in approximately 40% of the patients who progressed on AIs. So in accordance with the current guidelines, SERDS mutation testing would be advised for this patient. Testing for AKT mutation would not be incorrect, as these mutations play a significant role in resistance to endocrine therapy. The most common alteration is the PIK3CA mutation, observed in 30 to 40% of HR-positive breast cancer. Therefore, it would be appropriate to include PIK3CA mutation testing in this setting. As you can see from the biopsy results, the test has identified a PIK3CA mutation. No other mutations were identified. Which therapy would you suggest moving forward with? Here I picked the combination of alpelisib fulvestrant, and this is in accordance with current guidelines and supported by the results from the SOLAR-1 trial. So alpelisib plus fulvestrant, given the presence of PIK3CA mutation, could be a suitable option for this patient. We have now chosen alpelisib plus fulvestrant, a second-line treatment for Alice. As such, which grade 3/4 adverse events can we expect more commonly with this treatment? The hyperglycemia and diarrhea, indeed, these were the most frequently reported adverse events in the SOLAR-1 trial. It is important to counsel patients for the occurrence of these potential side effects, in particular to advise on some dietary recommendation to control diarrhea. And it's also very important to screen for baseline risk factor for diabetes and to try to optimize blood glucose before alpelisib initiation for those patients presenting with a condition of prediabetes or frank diabetes. So we are moving to the conclusion. I hope you found this patient case informative. So we have discussed about a patient with hormone receptor positive to negative metastatic breast cancer. It is important to guide precise treatment decision to assess tumor characteristics, including the assessment of prevalent mutations like SL1 and PIK3CA. As you have seen, this mutation can significantly influence and guide treatment choices. So I would like to thank you for helping me in discussing this case. And don't forget to take a look to the first IPCV discussed by my colleague, Dr. Elisa Agostinetto. Thank you all.